So good evening, ladies and gentlemen. Sorry, we're slightly late this evening. We were involved in the earlier press conference with the Taoiseach and the Minister for Health and the Minister for Education. So today we're reporting to you an additional 480 new cases that we have diagnosed in this country, bringing the total of those confirmed in Ireland to 7,054. Reporting to you there have been an additional 25 deaths, bringing the total number of deaths since the beginning to 287. And again, I would like to express my condolences and our condolences to the families and friends of each and every one of these individuals. These additional 25 deaths, 11 of them are female and 14 are male. We have reports that 16 had an underlying medical condition. In terms of the full 287 deaths, a more detailed report on those, 200 of them occurred in a hospital setting, or 70%. 31 occurred in an intensive care unit setting, approximately 10%. 242 report an underlying health condition, 84%. And the male-female breakdown is 175 were male, 112 were female, that's 61% and 39% respectively. The median age was 82. And we've been asked before, the mean age was 70, so a difference accounted for by the fact that there have been some deaths in quite young people in their 30s. The range of deaths, for your interest, is from 32 to 105. As of midnight on Wednesday, the more detailed report on all the cases diagnosed at that point, midnight on Wednesday just gone, the night before last, 7,071 cases. 1,631 of them had been hospitalised, that's 23%. 244 admitted to an intensive care unit, that is 3.5%. They involve 339 separate clusters, accounting for 1,512 or 21% of the cases. We have reports of 1,949 in healthcare workers. The median age of all of those cases, incident cases, is 48. In terms of the additional German samples that we've been reporting to you each of the evenings so far this week, there's an additional 216 positive reported today, and that brings the total reported positive through that mechanism available to us from the HPSC at this moment to 1,035. And if you add those to the earlier total I gave you, that is additional and brings us to 8,089 in terms of total numbers of cases. That is reflected each day in the total number of detailed breakdown, the one that I just gave you, the 7071, that includes those cases, as I said it would earlier in the week. We have, in terms of a more detailed picture for intensive care, 251 people admitted in total thus far, 157 remain in intensive care, that's 63%. And we've now seen 62 people discharged from intensive care, or 25%. There have been 31 deaths in intensive care units, that's 12.4%. And 203 of those intensive care unit admissions report an underlying medical condition, that's 81%. And the median age of the intensive care admissions is 61. In terms of nursing homes, just a little additional information in relation to this issue, giving rise to our continuing concern and focus on this particular sector. So nursing homes and residential settings in general in the community. There are a total of 207 across all residential settings where we have reports of a cluster, 135 of those being nursing homes. That's 135 out of approximately, we think, 550 nursing homes. Of the deaths that we've seen in this country so far, we have from our public health teams that are working with the nursing homes reports that allow us to identify 156 of those, we think, are 54% arising in those settings in the community. In those nursing home settings that I've told you about, the 135, we have reports of symptomatic cases in 1 in 5 approximately of the staff on average, and 1 in 6 of the residents. So quite a high rate of infection in relative terms compared to the community at large. And just to underscore the point that we've been making all along, that we are concerned about the rate of infection. But as our data shows us, still quite a large number of nursing homes without any reported clusters at this point in time. And that will be a continuing focus of us to try to prevent infection spreading into those nursing homes and to mitigate the impact of the infection in the nursing homes that currently report it. This is a pattern that's confirmed and seen in every country in Europe, and you'll see it in the ECDC reports around nursing homes and residential settings as a particular challenge given the profile of vulnerable people, and we've been saying that since the beginning. In terms of just the final part of the update, our National Public Health Emergency Team met today. You'll be aware, I'm sure, after the consideration it made this morning and the ongoing consideration over the last period of time, has concluded that given the state of the infection, and we shared with you quite an amount of the modelling information that we have, the fact that we still don't have certainty if we're slightly above 1, slightly below 1 in terms of the reproductive number, the fact that we believe that we need to continue to monitor that. We're not certain that the growth level is a level that we can cope with. We are concerned about that on an ongoing basis, and as I said, we're concerned about the spread of infection in nursing home units and other residential settings, and for these and other reasons we think it's important that we continue the measures that are in place, and we've recommended that those measures continue up to and including the bank holiday weekend at the beginning of May, so that's until the 5th of May in total, Tuesday the 5th of May, and those announcements were made after government agreed and accepted those recommendations. They were made by the Taoiseach, supported by the Minister for Health and the Minister for Education a little earlier this afternoon. So, happy to take any questions. Zara?
Zara King, Virgin Media News. Tony, I know this is a question that you're asked probably every night here, and you were asked a couple of times by our colleague Hugh O'Connell this afternoon, and we're looking just for a number, if it's an estimate or a number, of how many people are waiting to be tested. Can you give us that number?
So I don't have a precise number on that, and I'm not being evasive. We think now that the position in terms of access to both sampling capacity and testing capacity is such that anybody who is identified who needs to be tested, whether that's in a hospital setting or whether that's because they're a healthcare worker or otherwise fall into one of the priority groups, or indeed somebody who's referred by their GP, can have access within a short period of time to testing. That's the important thing, that we get rapid turnaround. We've had a challenge, we've been very clear about that, in terms of the speed of turnaround of that testing, particularly in relation to community testing over the course of the last number of weeks. We've been upfront about the reasons for that. What we now have to do is looking forward to try to build that capacity as quickly as we can. There are measures taking place literally today, tomorrow, over the weekend, to grow that capacity through a variety of different mechanisms, new laboratories, new arrangements with laboratories potentially outside of the country. Nothing left tried, if you like, in terms of growing that capacity, because one of the things we will need to do in the period of time that we now have until the 5th of May is to look at making our case definition, which you're aware is the thing that drives, if you like, the diagnostic process, more sensitive than it is at the moment, to increase the chance that we will pick up cases of infection if we do move to a situation whereby the measures that are in place now are to be lifted. We're not in a place where we're ready to lift those measures yet, because the disease has not got to a point where we think we've got sufficient control and that we're satisfied enough about that. But if we get to that point, we need to have capacity in our system to ensure that we can test in real time, and I've said that in a couple of evenings. That means a test sample being taken and being analysed either on the day or the following day. And that's the only means in which we can rely on a system giving us the kind of responsiveness we need, that kind of turnaround. We think that will be a substantially greater testing capacity than we have in the system at the moment. A number of people ended up waiting for substantially longer periods than that, much longer than we would have liked, much longer than they would have liked. Arrangements have been put in place through those German contracts that I've mentioned to you over the course of this week. I've given you the numbers day on day that have come back, both the numbers of samples done each day and the number of positives resulting from those samples. And I know that the total number of those now in terms of tests, I don't have a precise number of those, but it's well into the 60,000. So it's in the region of 64, 65,000 if we add all the samples done here and the extra ones that have been contracted through that arrangement in Germany. And my understanding now from Paul Reid and his team in the HSE is that that sampling process in terms of completing those will be complete in the next number of days.
Can I ask you just in relation to those, because was it yesterday you said there was 427 positives back from Germany, was that correct? Scribbled it down.
I will tell you.
I'm just curious to know...
I did say that that was the additional number I had yesterday, and I gave you that number again today of 216.
Just the one thing that we're confused about is just, when is that going to be added to the total confirmed cases? Because total confirmed cases is obviously 7,054 now. So when do we add Germany into those?
I can help with the confusion. If you're confused, I'm very happy to do that. So the number that I gave you of 8089 includes all of them. That's everything. The number that I gave you this evening of 7071, which is the detailed breakdown as of midnight on Wednesday, includes any reported back positive up to that point. The number I gave you yesterday evening of 6444 of the detailed breakdown to Tuesday evening, which was midnight the night before, included all the positives up to that point. So we've included them, I've reported them to you separately and in the detailed breakdown each evening over the course of this week. So they've always been reported to you.
Oh yeah, no, it's just so, like, obviously on this press release that we get, the total confirmed cases now are 7,054. So are you saying the actual total confirmed cases is 8,089 then?
So that's the total number now. So allow me, if you don't mind, to answer the question.
Sorry, yeah.
So that's the total number. We did say over the course of the week that we would report them separately and then give them as a total into the modelling team. You can check, that's what I've said every single evening.
Oh no, that's fine. I just was wondering because it's,
There is a reason why we report them separately, not because we're trying to obscure them, but because those tests, particularly those that were done in the early part, relate to tests that are quite old. And I've been asked the question here about whether some of those tests would go out of date and so on. So they're tests that go right back to the middle of March. And if we reported those simply as part of the daily increase, it might appear to you like it was actually the number of cases being produced by the disease day on day, and it would give you a false sense of that. It isn't. So the number of new cases arising from the disease each day we report as a figure, and that's the figure today of 460. Yesterday,
I suppose the term total confirmed cases perhaps is a little bit misleading. Then maybe it needs to be total based on the 24-hour period. You know, I think it probably needs to be a bit clearer that they're all together. Do you know what I mean? As in, if it is 8,089 total confirmed cases, there's a big difference.
There's no if about it, Zara. That is the total, and I've given you that figure. And the total number of those day on day that we report that are diagnosed in this country, which is the number that tells us the impact of the infection, and tells us each day what in terms of new cases arising in the population is the total number of additional cases. That figure today is 460, was 500 yesterday. That's the figure that we see represented on the graphs that Philip gave to you yesterday. And what we will do, and I said each of the evenings over the course of this week, this information will be made available to the modelling team. Each of those cases will be plotted into the model according to the date that the sample was taken. And you'll see two things. You'll see, first of all, that it makes no difference, if you like, in terms of the slopes of the line that we saw yesterday. And you'll see that they spread out over a substantial period of time. But the way that they're being done in large numbers, which is useful through the contract in Germany, makes it appear as though it's a significant increase in the number of cases that are occurring now. And it's really important that people don't think that that's what it is. These are old cases that were done over weeks ago, being reported together, not new cases occurring in the population today. So the number of new cases occurring in the population today and tomorrow, that's the important thing for us to track.
No, totally, but I think the overall total is important to be, you know.
It is.
Yeah.
It is, but actually it's much less important in terms of what we track, the cumulative number, than the number of infections that we see day to day, the number of ICU admissions that we see day to day, the number of deaths that we see day to day. So it's the change in those numbers day on day. That's the thing that indicates the behaviour of the disease. There's very little that total number is going to tell us that we know that's going to inform our public health management. I understand it's an interesting question, but it's not the question that so the cumulative number of total cases, although we give it, is not something that informs the ongoing management. What informs the ongoing management is the number of new cases each day, the number of ICU admissions each day, the number of hospitalizations each day, the number of deaths, unfortunately, each day. And we report those figures each day for that reason.
No, absolutely. I just think probably from our perspective of reporting to the public what the total number of confirmed cases is day to day, we need to be able to give people the full picture of all tests that are done, irrespective of the time they were done. So I actually think, is it not fair for us to move forward now saying our total number of confirmed cases is 8,089?
That's why I gave you that figure.
And great. No, but that's great. But maybe we should put that on the release every day so that we can move on from that point. Do you know what I mean?
So the release has included both the run rate, if you like, in other words, the number of new cases and the total of that each day, as well as the detailed breakdown from the HPSC, which is usually 36 hours behind, and all of them are included in that. You'll see that figure today is 7,071. It's not 8,089. So there's a lag of about 1,000 there, because it takes a period of time after a case is reported to the HPSC for that to be included in the detailed analysis. And that's why I say each day to you, and I've been doing this all along, that this report, which is more detailed, is as of midnight the night before last. It's running about 24 hours behind the total. But the total number, which I've given you there, is 8,089. That's the correct number, and that's the number we'll give you every day from this point forward, including all samples, irrespective of where they've been done.
No, thanks. I appreciate the clarity, just because it was, thank you. And I just wanted to be able to kind of...
I hope you know I'm always happy to clarify.
Oh, no, in fairness, you are. No, in fairness, you are, and I appreciate that. So thank you very much.
Okay, thanks, Sarah.
Tony, I tried to follow it, but I am so confused. I'm looking at the European Centre for Disease Control. It said, as of yesterday, and today's figure, 7393, and we were reporting 6574. And I feel it's a bit like there's somebody's put a pea under a cup that you see in these circuses at times. I moved it around and I don't know where it is. I've heard the numbers, but they're flown over my head, and I don't know. We've been reporting the number in the press release each day, and it clearly wasn't the total in terms of positive cases. And I can understand from your point of view that the modelling is absolutely critical, 100%, and I accept what you say.
Yeah.
But from our point of view, the information is critical that we're giving to the public. And we have not been given them in the recent days the total case load. And you see, the public doesn't understand the modelling exercise. They do understand this number. And I don't know, because there were so many numbers there. I don't know how many went to Germany. I now don't know how many came back each day. And I don't know what the real number is.
I'm happy to spend whatever time you want to spend helping to clarify it for you, George. Each evening, I've given you the total number of cases that we have diagnosed in this country. I've given you the total, as a result, that's diagnosed in this country. I have then separately reported the number of samples done each of those days in Germany from the point at which that began, and the additional number of cases that represented. I didn't put the two together because that would create the impression, as I've already explained, that these additional cases, which go right back to the middle of March, would be new cases and might give a different impression, not to you, but a different impression to anybody looking at the track of this disease, and make it appear as though they were current cases when in fact they were historic cases. And it's actually genuinely important to try and separate those two things and not confuse cases that occurred 2 and 3 weeks ago with cases that are occurring now. The really important thing for us to track on an ongoing basis and to report in terms of the behaviours disease is what's happening now, as current as possible. We don't ever want to be in a situation, not just because an individual is waiting for their test, but because the information it generates for us to not be in a position of reporting real-time information. And we've had a challenge in that because we've had constraints or limitations or challenges in the supply of a number of steps. Over the course of the last number of weeks, we've had a challenge in terms of getting testing centres established so that people get sampled quickly enough. We've had a challenge in terms of supply of swabs at a different point because there was an international, let's say, supply issue in relation to that. When those issues were resolved, there was a challenge in relation to the laboratories and the absence of sufficient quantities of reagents. And the result was that there was a waiting time introduced that wasn't part of the original experience that we had with this disease, where all tests were being reported within a 24 or 48-hour period, which is what we want. But some of those tests were taking longer, and we were forced to prioritise then. And we were clear on what those prioritisation criteria were, and they were right. We said that people who were hospitalised and who were ill, and healthcare workers and some other priority groups would be the ones we would focus our testing on if we didn't have enough testing capacity to test everybody or every sample that arose during the course of a week. And that then resulted in delays for people in the community. And some of those delays became quite lengthy. And that it resulted then in a situation where a number of, a contract was put in place by the HSE to test those samples where people were waiting for long periods of time. Individuals obviously wanted the result of those samples, and some of them are quite old. And so that's the reason that we reported them separately, because it would create an erroneous impression for you and for everybody else that this actually was giving a sense that the behaviour of the disease was such that an additional number of cases occurred in the previous day, 2-3 days, that hadn't in fact occurred in that 2-3 days. They'd occurred weeks previously. That's the reason we reported them separately. And I said I gave the figures to you each evening. I told you why we were reporting them separately, and I said that we would feed it into the modelling information, And we've done a little bit of that, but we haven't enough to give you a full report. We'll give you that report next week
Well,
on
can
the
I
modelling
ask
information.
something? Because
And just the final thing I'll say on it, George, is that when you plot these according to the date in which these samples were done, which is a much more realistic sort of assessment of when these cases actually arose, you'll see that they arose over a long period of time. They spread out, and they don't actually change the slopes of the lines and so on that you saw here yesterday evening. You'll understand that.
I do.
So, for example, and I think Philip addressed this particular question, one of you asked him, how do you take account of that? Are there missing cases we didn't know about? And he explained that the model that he has correctly accounts for missing cases for a variety of reasons, either because there are asymptomatic cases occurring in the community, or there are very mildly symptomatic cases where people don't come forward for testing, or in this case where some tests were done and the actual processing of those tests didn't happen in real time in the laboratory. So the model accounts for that up to 50% of the time and takes account of that factor. So it doesn't have any impact on the model or the conclusions, and I think that's an important point for people to take.
But the thing is, we have two numbers tonight.
No.
We have a number in your press release which says 7071 or something, so and we have 8089. So which one are we to report?
So I would, well, I'm not going to tell you what to report, but I would suggest, George, and what's true, 8089 is the total, and 7071 is the number as of midnight the preceding night, which we give you a more detailed report on, because it takes time to do that more detailed report. We've always reported that the more detailed breakdown is as of midnight the night before last. I've always said that. I'm sure you've heard me saying that each evening. So that figure is a more detailed breakdown and always runs behind the total number of cases. So the 8089 is the total up to as close as we can report it, but the 7071 is as of midnight on Wednesday night.
But how long will it go on that we've got the two numbers? I know Irish people are very good at ambiguity, and I'm pretty good at it, but I can't handle this one.
So this isn't ambiguity, George.
But it is in terms of when you've got two numbers and you're trying to decide, and you leave it to us to decide which one to report.
No.
It's difficult.
I don't think that's a fair characterisation of what I'm saying, George, if you don't mind me saying. What I'm saying to you is that, and this is normal in terms of surveillance activity, we can have a very up-to-the-minute total, which is the 8089. So
that includes the German swabs.
That includes everything, right? That's the total.
The 7071.
So 7071 also includes the Germans up to that point, okay? So the 8089 figure is, if you like, if I can put it this way, bang up to the minute, as close as I can get it for you before we walk in the door here. That's the total number of swabs. They're in the process, some of those diagnosed today, of being reported to the HPSC. They go into, which is the surveillance centre, and they go into the surveillance centre, which is the HPSC, and they're subject then to more detailed analysis and reporting that allows me to tell you how many are in hospital, how many are in ICU, how many are males, how many are females. That takes a little time. So detailed surveillance reporting always runs a little bit behind the most up-to-date sensitive picture. That's a normal part of any infection. If you name an infectious disease that's occurring in the population right now, or any other pandemic, the reporting of the total number of cases will always run a little bit ahead of the detailed reporting, because it takes time to do that detailed reporting. That's just a normal part of surveillance activity. And those two figures are not inconsistent.
Okay, but Tony, I'm looking at the number here, and I'm sorry to labour it, because it's kind of important to do it. Right?
I'm patient. I'm happy to answer your questions.
The number informed today is 480. This is in the press release, right? And there have now been 7,054 confirmed cases. Okay, fair enough. Confirmed.
Well, let me just, so these have been confirmed in the laboratories in Ireland. So the laboratories in Ireland thus far have confirmed 754. The additional 1035 brings you to 8089 is the total number, and I've given you the figure each evening. I'm simply adding those two figures. I've given them to you all week, and I'm adding the two figures for you to give you the total of 8089.
Okay, so 1035 came back from Germany so far, positive, really.
Correct.
And more will be coming in the coming days.
Yes.
You gave one figure there, which was 64 to 65,000 sampled tests have been done. Am I right? Did I get that right, as you were saying?
Yeah.
And we were talking earlier this week, Colin, I think 24,242, I think, was the number of tests that had been done, or something like that, some number like that.
No, it's bigger than that, George. I'll have
42,000, sorry. 42,242.
Now you're correct, yeah.
Is the difference between them broadly the amount that was sent? How many were sent to Germany?
So two things have happened. So over the course of the week, quite a large number have been sent to Germany. and I'll give you a figure, and this is a guesstimate, and if you accept that this is a guesstimate, I don't have a precise figure on this. It is somewhere probably in the region now of 14 to 16,000 that have been sent to Germany and that have come back. And then
sent to Germany and come back, or sent to Germany? Do you know what I mean? Is will there be more?
There will be more.
So it's more than 16,000 will be going to Germany.
Yes, and so what I'm telling you is we'll keep reporting them to you until it's all finished. And my understanding and expectation, based on what the HSE has informed me, is that that'll be done within the next number of days, and so that'll be complete at that point. So that extra number that you've referred to, in other words, the 63-ish thousand tests that have been done so far in total, includes the Germans, the 42,000 that you talked about up to Monday of this week, and the additional testing that have been done since that point in Ireland in the laboratories. And bear in mind, that was as of Monday evening. Today is Friday. There have been a substantial number of tests done in Ireland since that time as well.
You see, when I looked at the European Centre for Disease Control figure this evening, the deaths are exact same. And this is the first time I've noticed that their number is different to the number we get. And I presume, and it is related to the German tests. So it's very confusing, Tony. It actually is. And I'm just wondering, how long will it go on?
So there's no it, George. I'm sorry.
But they weren't different before. It's only in recent days they've begun to.
Well, I haven't seen the ECDC report that you're referring to there to check
on the website.
And so I'm sure it is, but I just haven't looked at the ECDC website.
And also our own Health Protection Surveillance Centre uses the number that you had and that we report on the news each night, but the number on the ECD website is different. So there's a lot of confusion in around this.
So the it, George, is, if I can be as clear as I can, there will be two numbers, and there will continue to be two numbers. Not because it's simply that the very up-to-date number that hasn't yet been subjected to more detailed breakdown, because there isn't time to that. So the up-to-the-minute figure for the total number of tests is that 8089 figure. So that's I'm trying to, in giving you that figure, give you as timely a figure as possible. The other figure that has to lag behind, because the nature of surveillance, the processing that it does take time. There is a lag in that. If you want me to give you, and I accept that you do, and I want to be able to report this information in the way that we always do, more detailed information in respect of all of the cases, like the age, sex breakdown, whether they're in hospital, the numbers of ICU admissions, that's all important information. It takes time to analyse information in that way, and therefore the number of cases subject to that analysis will always lag and be lower than the total number of cases that's up to the minute diagnosed. And that's why there are two figures there. And that's the explanation. And so when you say when will it end, that won't end. That will always be the case. I'll always try to give you a very up-to-date figure, and a figure which is comprehensive and broken down as much as that.
And are we likely to continue into the medium term sending swabs to Germany? I would understand that you want 24-hour turnaround and less. So in the long run, it's not feasible.
So the intention now, as I mentioned, is a different point. And where I want our collective focus to be is on growing the capacity of testing, sampling, contact tracing to get it to a significantly greater level than it has been in recent weeks and that it is now. There's a lot of intensive work happening in the HSE to do that. And I believe that the arrangements that are in place with this lab in Germany, we would like to see if we can find a way of continuing that into the future, to keep that arrangement in place for the purpose of continuous testing into the future, as well as adding in other labs in this country. And there is additional capacity being brought on board literally today with the new laboratory in Enfer to add to the NVRL and the laboratories all around the country. So there's exhaustive efforts been made by a team in the HSE to try to grow the capacity of testing. And I think the German capacity that was sourced initially for the purpose of dealing with the old tests, if it could be made available into the future, and if it is available to us on a continuing basis, will be really useful to us to try and ensure that we grow that testing capacity to the kinds of numbers that I think we're going to need as a country. Yeah, sure.
I noticed in the numbers the other day, the number of people who had died in intensive care, I think it was 27. The number who had died in hospital, apart from that, was 141. I'm just wondering, are you able to talk about the issue about how those 141, were they not entitled or whatever to intensive care, or why did they never end up in intensive care? Was it their condition, underlying conditions, and so on?
You might,
George, I'll take that question.
Yeah.
Okay. First of all, to assure people, we have intensive care capacity still right across the country. We'll be building up, I'll come directly to your question in a second, but I just want to give a wee bit of context, that's okay. So we have intensive care capacity right across the country. We're building up surge capacity in anticipation that the number of cases may go up. And as I speak today, there are over 110 empty critical care beds as part of that surge capacity, which we can man and which can provide care. Now, there's no question whatsoever of people either being refused or denied intensive care based on their need. I want to say that, I'll say another, there's absolutely no question. Okay. What happens in everyday clinical life, be it COVID-19 times or ordinary times or peacetime, if you like, is that clinical judgments are made about the likelihood of success of intensive care, given the trauma, the intervention, what's required, and given the profile of a patient. Somebody, for example, may be quite frail, may have multiple illnesses, and they may have an end-of-life illness, for example. So I'm absolutely satisfied, I'm saying this to you and to anyone else who's listening, that decisions being made by our clinicians in intensive carers right across the country are based on clinical need. We've seen situations abroad which have caused anxiety. That situation does not prevail in Ireland at this point in time.
Okay. Thank you.
Can I just check, George, that you're clear now and you understand what I'm saying and why I'm saying it? I wouldn't want you to leave with an impression
on the numbers.
On the numbers, that it's either confusing or that there's something here
I
that
suppose,
we haven't reported to you.
I think, Tony, in the end, it's our difficulty in picking which number to report. That's going to be the hardest decision. It's like one of your ethical decisions there. Do we report the number in the press conference or on the press release, or the one with the German numbers? That's a hard one. Because you said you wouldn't direct us with regard to that?
No, I mean, I'm not going to tell you how to report.
Yes,
you're
very
far
hard.
better at that than I am. All I'm simply saying is that the two numbers, the accurate number, which is the up-to-date number, I should say, is accurate, and the detailed broken down number is accurate. And they both contain the German numbers. They both,
okay.
They both do.
Could I just add, if it's okay, because I know there were questions in other days about our testing centres, open or closed. We are able to meet the demand coming through the health link system, through the community testing. So in other words, the people who meet the criteria for testing, we're able to meet that demand in testing centres, and we're confident that by next week, early next week, we'll be able to meet the demand coming right through based on the additional lab capacity that's coming on board.
Great. Okay, thank you.
Thanks, George.
Hi, Tony. Shane Beattie from News Talk, and you can imagine it's going to be about the same thing that we've been discussing. I suppose I'm just wondering, did you foresee this problem where you have a room full of people who are at a briefing every evening who didn't know about this until now and are trying to get their heads around it, and what the general public are feeling now? I mean, social media is alive with confusion over this. I'm just wondering, do you understand that confusion, and why you decided tonight was the night to put that figure out?
So, well, I was aware that there was confusion arising, and I wanted to try and address it as much as I can. Anytime any of you will tell me that you're not clear, you're confused, or we think there's something confusing, I will spend as much time as I possibly can, and we will spend as much time as we possibly can helping you to understand that. We know the information that we have is not always perfect. We know it's not always up to date. It's not always as comprehensive as we would like it. But insofar as we make interpretations from it, insofar as we base decisions on it, we will either point out how it informs those decisions or point out the limitations of those. And we'll always try to be as honest and open as we possibly can be in relation to it. And I'd be particularly concerned if I thought that people were confused about things that I thought could be explained. And I would put, and I'm sure give this commitment on behalf of everybody who ever appears here with me, the same commitment that we will put whatever time and effort into trying to help you with whatever confusion. That might not be your confusion, it might be confusion that other people are reporting that you're picking up on, or whatever. And so we have endless patience for that, Shane, so I'm happy.
So if you're doing an interview and you're asked, Tony, how many confirmed cases of COVID-19 are there in Ireland? The answer is?
8089.
Thank you. On to testing, and again about confusion. I know you're asked several times. Zara's asked you again this evening. Why can't, because people are giving out about this on social media, why can't we say how many people are waiting to be tested, and why can't we say how many people are waiting for their test results?
So my understanding, and again Colm's answer a minute ago to George, I think, says that we don't believe there are people waiting to be tested at this moment in time. And the capacity of our system, both in terms of both sampling, the taking of the swab, and the testing of that swab in a laboratory, is sufficient now to allow us to say that that's the case. There have been some people who've had to wait, and that's what the original contract the HSE put in place last week with the German lab was, to deal with that, to get those older samples that individuals wanted back. They wanted to get their own individual results. We knew there was a delay in those rules, and some people, and I heard people reporting, I think Fergal Barros had mentioned periods of time that went to 7 and 10 days and sometimes even more. And we understand that people wanted those tests back, and the HSE understood that and therefore contracted an additional service from Germany in relation to those relation to those tests. And my understanding and my information from the HSE is that the processing of all of those will be complete within the next couple of days, just after the weekend. That's my understanding right now.
Colm, can you give me the number then? How many are waiting on their test results?
Just because this question came up yesterday about some of the testing centres are closed, and they were because we actually have the capacity now to test in excess of demand coming through. You'll recall when the case definition was tightened up, it led to a rapid fall in the number of people referred for testing because we decided to focus on priority groups. So we've now got 49 centres. They're actually too many for them aren't coming through at this point in time. We need them further down the line, as we know. Right now, the story yesterday, for example, about one testing centre closed was purely related to the demand. We've given appointments to anybody who's referred for testing. The appointments are given out no further than 1 or 2 days or after a weekend, and we're able to meet that demand. The problem we had, as we've told you, Shane, is the issue over labs, which now, thankfully, is approaching resolution, and we're hoping to get to the stage where there'll be no delay at that lab level by early to middle next week.
Right. And I know the ethos of you want to provide clarity there.
Yes.
So why can't we say how many people, as of today, are waiting for their test results, who've gone for a test for COVID-19 and are waiting for their result?
I actually don't know because it was a dynamic number, but what I can tell you is that those remaining tests coming back from that external source in Germany will be coming through by Monday, Tuesday next week, and that will be. And after that, our lab capacity, building it up from today, the extra labs coming on today, will be able to meet the demand based on the current case definition. But of course, we're planning for a possible expansion in the future. So.
What I can say is that I told you my expectation is that will be complete within days. And as we've done every day so far this week, when they started to come back, I'll give you the number of those that we get every day. And we can certainly commit to doing that and continuing that as we've done literally since Monday of this week.
Thank you.
Okay, thanks, Shane.
Hi. You mentioned nursing home deaths a little bit earlier on,
yes,
I think.
I did.
Right? And I'm sorry, I may not have gotten the figure correct in my head. Did you say 136, I think?
I said, and check the figure, I said 156.
156 deaths in nursing home.
156 deaths are public health doctors, and so if I just explain for a moment, there are public health teams working with some of the nursing homes and residential centres where we have clusters. And on the ground, they're reporting information, and that information is coming to the HPSC. And 156 deaths have been reported by those teams where we have a lab confirmation of COVID-19.
Okay, so
that's our case definition. So that means that's 156. I gave you the percentage a moment ago, 54%. So 54% of the deaths, the 287 that I've given you in total, are individuals where they were residing in effect in community and residential centres. I'm not going to tell you that's a complete number now because we're looking into these things and we're looking into them, and let's say we're going to be studying that over the course of the next number of days, and we'll get firmer and firmer in terms of the information. But that's what's come back to us from the public health teams that are out now in the nursing homes and the way that we've recommended in response to the clusters that are there. 156 out of the 287.
The reason I bring it up is you mentioned yesterday that 72% were in hospital environments. So this includes obviously some of these.
No, it does. And so we think what's likely happening there is that it's an individual who's referred into a hospital and where the death takes place in a hospital, but the person resides in a nursing home or community setting, and it's the nursing home or community setting reports the death, or it's picked up by the teams working with those centres. And that's maybe not an unexpected pattern given the pattern of infection and the impact of COVID-19 on vulnerable groups and particularly older people. So we see people developing illness in a community setting, being referred into hospital, and then unfortunately a number of people have lost their lives in hospital settings. That 72% figure that I gave you is the figure for those, and that is a figure that reflects on where the death took place and not where the person lives. So the 156 reflects more where people are living. There are people who risk.
Okay, so it's people who've come from nursing homes but who've actually died in.
That's exactly what we think.
That would happen during a flu season. It would happen during any surge of infectious illness. Unfortunately, frailer, older people are more vulnerable, and sometimes they're referred into hospital settings where they pass away. And often they pass away within a nursing home based on their own individual profile and the wishes of family. And understandably, many people don't want to leave with their nursing home, and if they're coming to the end of their life for whatever reason, it's more appropriate for the care to be there rather than the trauma of transferring to a hospital setting.
And it also, there's no point, I would imagine that people who are of significant age, there's no point in going into intensive care because they probably wouldn't be able to cope with the level of care.
I wouldn't, just to make sure, it's not based, the decision to admit to intensive care is not based on age, it's based on overall profile and the likelihood of success of what is a very traumatic intervention. And just to assure people, because I know there's fear out there, these decisions are made every day by trained specialists, nurses and doctors working as teams. Intensive care is a system. It's not unique, a machine or a place. It's a system of it does what it says. It's intensive care applied to a patient that is extremely interventional and invasive and has is done as a life-saving measure. But to do so, the clinicians in discussion between themselves and families and the patients obviously will decide on the likelihood of success in any individual case, and that's how they make their judgment.
Okay, well, I'll ask about test centres then. Are there 50 test centres in operation around Ireland at the moment? Because we know Páirc Uí Chaoimh wasn't. I've heard anecdotally that a couple of others rurally aren't, and Croke Park was looking not busy yesterday, shall we say.
Just to go back what I said, I was asked this question yesterday. The reason it wasn't busy was because the demand wasn't there. So we have 49 test centres available. We have a capacity for that. Not all of them are open at the moment, simply because we have a capacity to test in excess of the demand coming through since the case definition changed. Before that case definition changed, it was a much broader case definition with many, many more people being referred for testing. Since the case definition became tighter and we prioritised certain groups, we have a smaller number of people coming through, and which are smaller than the capacity of our testing centres. So I can tell you today, for example, anyone who's been referred to Páirc Uí Chaoimh has received an appointment either today or after the weekend.
I'm just going to ask one last really quick question, which is a deal has been signed between the HSC and GMI to provide, I think, 900,000 cases worth of reagent. How quickly is that likely to affect the testing scenario?
That's the part of that planning is for us planning for expanded testing, because we've talked a lot tonight and other nights about the current problems we have since setting up this testing pathway, which we had to do in very quick time from zero only a few weeks ago. But part of our strategy has been well built, is planning for an expanded, responsive and timely testing should greater number of people be referred for testing in the event there's a change in case definition. So we're actively out there in the market seeking as many labs reagent material as we can, and this is that what you've just referenced is part of our strategy to plan for a greatly expanded lab strategy to meet any increase in demand that comes through from a changed case definition.
Neil Leslie from the Irish Mirror. I appreciate you've said you're not trying to be evasive and there's confusion around testing and backlogs and so forth. Pierce Doherty, the Deputy Leader of Sinn Féin, said this evening he accused the HSC of deliberately withholding information from the public on a testing backlog. Is that, would you respond to that?
When I'm not from the HSC, I'm not going to speak on behalf of the HSC as an organisation. What I can say, there's no withholding of information. All the information that we give you is as honest and open at the point at which we give it to you as we can make it. It isn't always perfect. It isn't always timely as we would like it. It isn't always as complete as we would like it. And as I said earlier on in response to an earlier question, I think we'd always try to make sure that either it is both accurate and complete, or where we think that there are issues in terms of accuracy or completion, we would try to point those out as honestly and as openly as we could. And we'll continue to do that. And at times, explaining the information is more challenging than at other times, and it's taking more time to explain this information to you this evening, and we're happy to spend that time if it helps in terms of creating clarity for you in terms of the information and what it means. And I don't want to digress in terms of the question that you're asking me. I haven't seen Deputy Doherty's comments myself. But there is no withholding of information by anybody. In fact, our objective is, in as much as we can, to try to supply as much information as we can to the public, to have and to hold the confidence of the public in the way that we do that, because ultimately that plays into the extent of buy-in, of belief, trust in the kind of information that we're giving, because ultimately that then determines the extent to which people will engage in and the kinds of behaviours that we're looking to try and have, the important behaviours in terms of hand washing and in terms of respiratory etiquette, social distancing, and all the other measures that we have in place across society. Also important for me to make the point, although we spend a lot of time talking about testing and looking backwards, our testing focus has got to be as a country looking forwards. Not, as I've said on occasions when I've been asked these questions before, because it's inconvenient for us to be talking about historical issues, but because it's much more important for us in public health terms to be looking forward to the challenge that we have to build our testing capacity for a situation whereby hopefully we're in a position to remove some of the restrictions that are in place, and we will need to then be absolutely certain that we have the maximum chance of detecting cases in real time in the way that I described earlier on, and that we have no capacity constraints in any part of the chain, whether it's sampling, whether it's testing, or whether it's contact tracing or flows of information in relation to any of that. And that's the kind of environment that has been recommended by the WHO, by the ECDC, and also by ourselves as part of our plan. And that's what we're working very hard with the HSE to do. So some of what you heard a moment ago in terms of the GMI contract is an example of some of the efforts that are happening in place that are right now to try and grow that capacity to not the numbers that we're testing at the moment, but to numbers that are much, much greater than that. And we know we need to do that very quickly. There are many other countries who are in a position well behind us in terms of the levels of testing that they've been doing, who are trying to grow that capacity, and they've been out there competing, if you like, in the international arena for the materials, for the lab contracts and so on, in the same way that we are, to try and grow that capacity as quickly as we can. And I need to make the point, and people are tired of me making with this point, so when we do talk about testing, for individuals in the community who have waited longer than we would want for a test result, it is still important that individuals, irrespective of the absence of that test result, if they have symptoms, self-isolate for the 14 days that we recommend, and that they restrict the movements of their household contacts, with the whole of society in effect now have restricted movements other than essential workers and very limited exceptions. But it's really important that for the purpose of suppression of the transmission of this virus as much as we can as a society, that where people have symptoms and until a test result comes back to tell them otherwise, to assume that they have the disease, even if that test result is taking longer than we would like. But we believe now, in real time, the testing capacity is such that people will not have to wait. They can be sampled and tested within the time periods that are requested, if you like, by their GPs. But our purpose in growing that capacity will be to deal with the much more sensitive case definition, and we anticipate changing that in the coming period of time.
Can you say that you're happy that any failure to build the capacity to this point in disease hasn't contributed to the decision made today to lock the country down for another 3 weeks? And could you assure the public that testing and not getting to the required targets of 15,000 won't be the factor in us not being able to ease restrictions in 3 weeks' time?
So I didn't put a number on the objective, but I'll come back to that in a second. So I'm absolutely satisfied that the right range of measures are in place and need to continue. And that's because of reasons in relation to the behaviour of the disease. And we have a number of parameters that we follow in relation to that, not just the number of new cases each day, the number of ICU admissions, the number of deaths in the population, the number of hospitalisations, and some of those will be independent of testing levels. And we don't think the testing has, although we haven't been testing, so I'm not happy. I can't tell you that I'm happy with the fact that people have had to wait for longer than we would have liked in terms of testing and testing results. We started out with a clear strategy to try and get people tested within a 24, 48-hour period. That's our objective. That was always our objective. That will continue to be our objective, and our strategy was always to test as many people as possible. We have had to have people wait for longer periods than we would like for reasons that were beyond our control, and related, as we've said, and I won't go through them all individually, but very often to the supply of essential materials and essential parts of the process, whether it's sampling, whether it's swabs, whether it's laboratory capacity. And that's created a challenge for us. But it hasn't contributed to the understanding of the disease that's informed our decisions. So the information we shared with you yesterday evening around the modelling, the information we're giving you in terms of numbers of ICU admissions, the information we've given you in terms of growth rate and the changes in relation to that overall, as well as those same trends applied to hospitalisations, intensive care units and deaths, all of those things go into forming the analysis that we use to make the recommendation. So it's not simply driven by the total number of cases and any impact that a number of test results might have at a point in time. And as I said earlier on in response to an earlier question, that the modelling data builds in an assumption that we will miss a certain number of cases in the population. I think Philip Nolan said yesterday, for every 5 cases we think we pick up, the models allow for up to 5 cases being missed. And the reasons that they may be missed are many and varied. It could be because, as we've said, of asymptomatic transmission or very mildly symptomatic cases that don't come forward looking for attention of a GP, for example. And then also because a test might have been done and the result wasn't available to us because the test result wasn't processed. So for any of those reasons, we could have missing cases. The models take account of that. The conclusions we've based our decisions upon are based on the models. And so I can absolutely assure you that any of this testing capacity had no impact on the requirement that led us to advise government and government's acceptance of that recommendation to continue the arrangements we've had in place for the last fortnight for a further 3 weeks.
Will we have a fit-for-purpose testing and contact tracing regime by the 4th of May?
That's absolutely our intention, Paul, and I can tell you there's intensive work happening in the HSE to ensure we don't have that right at this moment in time, and there are a number of steps to that chain. And I know that the HSE has been redoubling its efforts in that regard in recent days. They have strengthened the team that internally within the HSE, you heard me saying that earlier on, to enable them to do that. And there are people literally working night and day on that, whether it's in terms of the sourcing of reagents and the sourcing of kit and material, or whether it's in terms of the development of laboratory capacity within this country, and whether it's the sourcing of commercial laboratory capacity outside of the country. There are literally people working and will be through the weekend to grow that, because we simply have to be in a situation whereby we're able to do a substantially greater number of tests now, or sorry, in the future than we're doing now. And we need to be able to, with that testing capacity, assure people that even if we have a very sensitive case definition, that we will be able to test everybody where a test is required, and to do that in real time. And by real time, what I mean is on the day or the following day, you get a sample and a result. Because in a situation where we have suppressed the infection in the way that we think we have, and we hope we will continue to do over the course of the next days and weeks, we really want to be in a situation then where we have the maximum chance of picking up a case where one occurs. And we can't be in a situation where some of the delays that we've seen, even as long as 2 and 3 and 4 days to have test results, are part of it. We can't be in that situation. So the planning in the HSE is all directed and focused at trying to ensure that we have that capacity in place well before the 4th of May.
So it sounds like you're saying you're in the hands of the HSE. We all are.
Well, the HSE is the delivery organisation that organises and plans and delivers all of the health services. And the clear intention of both government and the Department of Health and the HSE collectively, no difference between us, is to grow that testing capacity, contact tracing capacity, sampling capacity, the information systems to support that as quickly as possible up to the kind of scale that we need. Now, it's a scale, by the way, I should say, Paul, that is well above what many other countries are planning, because many other countries are not on the path that we're on. They're not planning the kind of testing capacity that we're planning. And many of those countries, and I won't say necessarily as a consequence, have had vastly different experiences of this infection than we've had, have seen very significant impacts on numbers of people being hospitalised, numbers of ICU admissions in particular, and you'll be well aware of those, and numbers, unfortunately, fatalities. The information that we gave you yesterday evening has shown encouragingly in this country, albeit with challenges that we've had, they have not interrupted our public health management and decision making. Our public health management and decision making around this disease has allowed us to bring the reproductive number and all the other associated measures that we track down to a level where it's at or close to 1. And we think that's a very significant amount of progress, has prevented us from getting into the kind of terrible scenarios that we forecasted could happen if we didn't make the kinds of impacts that we had intended to make. And we know that this has prevented very significant numbers of infections and the consequences of that in terms of hospitalisations, intensive care unit admissions and deaths. So we've saved many, many, many lives as a consequence of the society's efforts over the course of the last month, 6 weeks, since some of these measures kicked into place. We're looking now for further progress on that, and then we have to be sure that our public health capacity is, if you like, lightning quick, if I would say that, in terms of the potential detection of cases if there's to be any, let's say, increase in cases occurring after a point at which we might think about easing some of the restrictions that we have in place.
When could we look forward to a revised case definition then, a more sensitive one?
I won't give you an absolute commitment on that, but we'll need to work with a revised case definition for a period of time before we get to the 4th of May.
Okay, and just, sorry, the only thing about the figures, the main thing I didn't understand, why is the time lag figure of 7071 bigger than the today figure of 7054? Is that because 7071 includes
No, the 7054, that's the number done in Ireland so far, and then the 1035 is the number done in Germany. If you add the two of those together, you get the total number tested in the country so far, irrespective of who's tested them, of 8089.
Yeah.
And that's like up to the minute test positive results that were analysed this morning, for example, in the virus reference laboratory or laboratories. Yeah. They're included in that figure. And the 7071, that was the total at midnight the night before last.
I know, but it's bigger than 7054.
But that's because it includes all the German ones up to that point.
All right.
It does include all the Germans up to that point. They're all in there.
And just finally, masks, did you consider that today in the light of the ECDC?
So we're continuing that on a continuing basis. We didn't give further consideration to that one today. We had a big agenda, as you know, this morning, and an important decision to make to advise government on. That's what we focused on today. We'll be returning to the issue on an ongoing basis of masks, both for healthcare workers and also in terms of the question around the general public, because we know that that's a question that gets, but to be absolutely clear, that we follow the advice of the WHO. We do not recommend masks for general use in the public for the reasons we've stated before. We think there are potential risks and unintended consequences, and that it may lead to a false sense of security and a lack of maybe compliance potentially with some of the other important behaviours like hand washing and social distancing and so on. We'll obviously keep that under review, but we think we have the right strategy in terms of use of masks at the moment in terms of both healthcare workers and the population generally. Thanks, Paul.
Cayman Burke, thejournal.ie. This is perhaps a question for Dr. Henry. In the UK, pregnant healthcare workers are being advised not to attend work after 28 weeks gestation. The HSE doesn't make this recommendation and says that the UK guidance is not evidence-based. So the INMO has actually approached the HSE about this, and I just wondered if you could explain the thinking behind the decision and the reason for the two different approaches.
Well, we provide our group through an expert advisory group that reports to NEFIT. So that group, which considers all evidence, including international guidance, up-to-date evidence, which is changing all the time. There are a number of variations between ourselves and other countries in terms of advice given, whether it's PPE or whether it's pregnant workers. But certainly if there's a change in the recommendations in the UK, that's something that EAG, which meets regularly a number of times a week, would be considering. So our advice is never static. It's adaptive and changing all the time, as you'll have seen the past few weeks.
Thanks, everyone.